Hello and good morning. So it's a great privilege to be at IPCI and to present after Sharad and Damodar, who are very good friends, and we've been working together for many years. So I'm not a CTO operator like Sharad, so it's not a CTO case. It's just an interesting case. So the patient is a 65-year-old male with hypertension, had previous PCI to ostial LAD. Wrongly, I put it ostial circumflex. Ostial LAD 3 years back, for which we had no records it was done at an outside hospital, who presented to us with chronic stable angina for a year now, which was class 3, evaluated on OPD with a stress MPI, which was had severe ischemia in the inferior posterior wall, had ejection fraction of 40% with viable territories in the inferior and posterior wall. So this was his angiogram that I did. So we don't know where the ostial LAD stent is starting. The left main appears very short, and we don't see the circumflex at all. The circumflex looks like a large vessel which is filling through some diagonals from the mid LAD. And on the spider as well, we see that circumflex is somewhere there, but we don't see it, the ostium of it quite well. On the right, we see it's probably a codominant right with some collaterals to the circumflex, but the major collaterals to the circumflex were from the diagonal and some from this PLV. So the questions are, where is the LAD stent starting, where is the origin of the circumflex, and where is the left main, which is extremely short. So first we put a wire in the LAD, and then the first important thing is, whenever we have a situation like this, we need to be sure whether the stent, first wire is inside the stent. So of course you can do imaging at this point, but to save money at that point of the procedure, we check the LAD wire by putting a small balloon and taking a stent boost, which clearly shows that the LAD wire is intra-stent. Then we first fixed the mid LAD because it was proximal to the diagonal, which was giving collaterals to the circumflex. And then the mid LAD was fixed appropriately. Now this, although we don't see the proximal part of the circumflex, but going retrograde through this diagonal is probably very, very difficult. So we start wiring the LAD. We start with the fielder FC. We cannot wire it. We take a crusade on the LAD wire that we already have. We again take the fielder FC. It fails. Then we take a XTA. It fails as well. So what do we do? So the specific reason that I'm presenting this case is that we do a pot. Because we don't know whether the stent in the, we feel that after the first angios that the stent that has been implanted outside is coming into the left main, but it has probably not been optimized in the left main because the stent diameter was looking exactly same all throughout the stent. So we do a pot in the left main with a 4.5 short balloon, and after pot we retry wiring, because there are multiple case reports that when we do a pot proximal to the bifurcation, sometimes access to the jailed side branch becomes easier. And that is what happened. After doing a pot with a 4.5 millimeter balloon, with the same crusade, we were able to finally wire into the circumflex with a Gaia 2 wire. All the runs are not here. And we again do a stent boost by putting the small balloon here, and we see that the stent, the wire has gone through the stent into the circumflex, which was jailed, and the pot really helped by probably opening the stent cells and increasing our wire maneuverability at the ostium of the circumflex. Following this, we dilate with the small balloon change to a workhorse wire, and then we do IVUS. But whenever we do imaging, we should have some questions in our mind. So the questions we had were, where is the stent of the LAD? What is the status of the left main? And where is the circumflex wire? And we know that LAD stent is in the middle of the left main. The wire in the LAD is intra-stent. The left main is short with a diameter of 4.5 and which is full of disease. And the LCX wire has gone through the LAD stent struts, which were protruding into the left main into the circumflex. So that also tells us now that the strategy of treating this circumflex will be a culotte and not probably a crush, because the wire has gone through the proximal most stent strut of the LAD. So that is what we do then. We dilate the circumflex, do a culotte from circumflex to left main, do a pot again with a 4.5 millimeter balloon, do kissing with two 3.5 millimeter balloons, and then do IVUS in both branches, and repeat a final pot as in the left panel. We get an appropriate result at the ostium of the circumflex. We get an area of about 7.43 with good distal left main and ostial LAD. And this is the run from the circumflex to LM, and you see a very short neocarina, which is always there in a culotte also. So neocarina is just not seen in a tap. So we see a very small neocarina. in the circumflex at the carina, and we get an acceptable result in the circumflex. So what is more interesting is whenever we put a stent in the ostial LAD, sometimes it comes into the left main. Why does it happen? This is a bench testing that I did a few weeks back. I always thought that I needed to do this. Now you see this is a 2.75 stent implanted into the ostium of the LAD, and a pot has been done with the 3.5 balloon. That is what you do in a long LAD stent. But here the stent remains at the ostium of the LAD because you start the pot from the ostium of the LAD. So it does not elongate. Now this is the same stent, same model. So you start with the pot distally with the 3.5 balloon and you see what happens. Sorry, it just moved, but still you will see the stent elongates significantly. And now the stent is in front of the circumflex. This happens in the left main, this happens in the LAD, this happens whenever you start the pot distally. So the proximal part of the stent has no axial support. So you start dilating from distally to proximally, the stent keeps on elongating. So you had started at the ostium of the LAD, it comes into the POC or in front of the circumflex. This happens in the left main as well. If you do a crossover with the 3.5 and you start pot balloon from distally, by the time you finish the pot, the stent is hanging in the aorta, it comes to the guiding. So this has been well documented now also with some studies from Japan, but probably changing of pot sequence, which I suggest will manage this, because if you do the first pot at the proximal part of the stent, it gets fixed and then it does not elongate backwards. So that is what probably happens in these cases, and that is why the ostial LAD always comes back. So ostial LAD is probably a left main disease. Start pot from the proximal most part of the stent to prevent stent elongation, which is generally much more common than stent shortening. And POT can help in difficult side branch access, especially when it is a jailed side branch. And imaging is very important in most of these cases to decide the best strategy. Thank you.